And today is all about balancing ACEs with hope. And just a real quick introduction before we jump in. I'm Dave Clausen, the director of the Mid-America Prevention Technology Transfer Center, and I'll be your host for today's session. If you have any technical difficulties, please just send me a message in the chat box, and we'll see what we can do to get things remedied for you. And a quick note, although funded by SAMHSA, the views expressed in this workshop do not necessarily represent the views, policies, and positions of SAMHSA. And for those that might not be familiar, we are the Mid-America PTTC for short. Yes, PTTC for short. That's a mouthful. But we're tasked with providing substance misuse prevention training and technical assistance throughout Missouri, Iowa, Nebraska, and Kansas. And this really means strengthening and supporting organizations' efforts to implement evidence-based prevention strategies, ultimately to promote safe, healthy, and drug-free communities across the region. And if you've been in the prevention field long, you know many folks say collaboration is the key to effective substance misuse prevention, but we're striving for something stronger than collaboration. You know, the act of working with someone to produce or create something. We want community. And that's from that fellowship with others, you know, having those common attitudes, interests, values, and goals. From a rural town's one-person prevention team to a county coalition and clear up to the state level leadership, we're all on the same team. And the more we come together to support each other on the mission, we can each make our communities safer and healthier. And at our core, we believe that prevention is better together, and together we are stronger. Now, we, the Mid-America PTTC, is housed at ACT, Missouri, and community is right there in our core because we've been serving communities at the grassroots level for nearly 30 years. And I'm going to turn it over to the executive director of ACT Missouri real quick, just to share a little bit more information about ACT Missouri. Chuck, it's all yours.
Thank you. This is Chuck Doherty. I'm the executive director of ACT Missouri, like Dave said. And since 1991, we've been providing, serving substance use prevention catalyst. We want to provide training, technical assistance, and consultation to coalitions, schools, and substance use professionals. We want to empower individuals and have empowered individuals to foster partnerships and collaborations that provide safe, healthy, and drug-free communities. Because of our experience doing that, we expanded our reach to include Region 7, the PTTC, Mid-America PTTC, Region 7, serving Missouri, Iowa, Nebraska, and Kansas. And thank you all for coming. And it looks like we had a big room to get this training started. Thank you so much for attending.
All right. Thank you, Chuck. Glad to have you with us today. And just wanted to take just a brief moment and reflect on the power of words. We are all prevention leaders in our teams, in our communities, and in our field. And together, we can use our words to really create positive change because words have power. And we want to put people first. Couple real quick highlights. We do have the PFS Academy 2020, our last webinar scheduled for August 25th. That one will be on cultural competence. The registration is on our website, which I can put in the chat box later. And if you're a techie, you like podcasts, be sure to check out the Mid-America PTTC podcast. That's available on all your major podcasting platforms. And lastly, invite you to check out our roll call video. So short little 5 to 15 minute long YouTube videos that provide a little bit of information, just some training tips, because we know y'all are busy and you might not have time to watch a full feature length film. And although in this day, we may all be very familiar with the Zoom platform, wanted to give you just a real quick little orientation for those that might not be as comfortable or experienced on the platform. In the bottom left-hand corner, you'll see the unmute or mute button. Right now, I've got all the participants muted. When we go into breakouts, you'll be able to unmute yourself and use your voice to share some stories and talk with folks in your room. Next to that would be your video controls to turn it on and off. Moving from left to right across the bottom, you'll see the participants. When you click that, it will give you a list of everybody that's here today. At the bottom of that window where it shows everybody's names, you can give us a thumbs up, a thumbs down, go slow, yes, no. Those are participant cues, and we'll be here monitoring those throughout, and we would love to hear from you. Also got the reactions across the bottom there as well, and the chat box controls. And the chat box is in that bottom right, and y'all are already filling it up, and I love it. I will be hanging out in that chat box with you today to interact and engage with you all. And lastly, you see the speaker view sort of towards the top right. If you want to change the layout as far as how many webcams you can see at once, where you want them to be on the screen, that is where you do that. And that's all I had for you. So I'm going to turn it over to the wonderful presenters today. And I'll tell you what, we've been looking forward to today for quite some time. So I will turn it over and we'll do some introductions with Dina, Jeff, Chloe, and Lauren.
Cool. Thank you, Dave. I'm moving over here. Thank you. Dina, I'll go ahead and let you jump in and talk about the HOPE website and start with introductions because you're up first. You see it?
There we go. So hi, everybody. My name is Dina Burstein. I think I'll tell you a little bit about myself on the next slide. But we're going to be talking to you today about the HOPE project. You'll see the slide again. That's our website. And we'll be talking more about that later on. So you can go on to the next slide. So, like I said, my name is Dina Burstein. I am the HOPE Project Director. I have been in this position just since January. Prior to that, I worked for about 10 years at Rhode Island Hospital doing unintentional injury prevention, research, and community outreach. And prior to that, I was a primary care pediatrician. And I'm really looking forward to sharing, what we've done with positive experiences and HOPE and working with you guys on how you can incorporate some of these principles into your work. So that's me, and I'll be talking to you again in a few minutes.
Hi, my name is Chloe Yang. I'm a research assistant working with Dina and Dr. Segi, who is not with us today, over at the Center for Community Engaged Medicine at Tufts Medical Center.
Hi, I'm Lauren. I am a research assistant working with Dina and Chloe. I'm the most recent addition to the HOPE team, and I'm also working with them at Tufts Medical Center, Center for Community Engaged Medicine.
Thanks, Lauren. And hi, everyone. Jeff Flinkenbach, and welcome back for those of you that joined my presentation yesterday on the science of the positive, where we started to get into some of the foundations of that framework, as well as positive community norms and how it also is one of the foundational elements for the HOPE work. And I would like to say that it's an honor to be speaking to all of you, and an honor to be working with Chuck and Dave. Chuck and I go back many years with some of the work with ACT Missouri, and I recognize some names and faces on this. So thank you all with the incredible leadership you've been doing around your state, as well as everybody that's joining us from other places. And so I had the honor of being involved with the HOPE research and some of one of the co-authors with some of the initial papers that we're going to be talking about, and working with Dr. Segi. Bob and I met actually when we were both in a position with the CDC. We're in a think tank, a 3-year think tank that was looking at what became essentials for childhood, looking at safe, stable, nurturing relationships and environments. And it was out of some of that work that some of the HOPE research then took off and then is continuing to move forward in some really exciting ways that we're going to be talking about today. So we're gathering information. Dave, if you don't mind throwing this URL into the chat box, you probably already did, knowing you. We're gathering information about what people want to hear more about. And then we can circle back around to Mid-America PTTC. We can bring this to you through the HOPE Center. We're just really trying to see what it is that people want to learn more about in terms of training and technical assistance. I'd like to have you jump into the chat box right away, if you would, and say, what is something that is bringing you joy during some of these really challenging times? Acknowledging that these are tough times for people. What's something that's bringing you joy during these challenging times? And so jumping into the chat there, I think it's really important. Oh my gosh, you all are flooding the chat. I love it. Kittens. Oh, favorite answer of the day already. Kittens, right?
4-month-old puppy.
Yeah. What's that? Go ahead.
4-month-old puppy.
Oh yeah. Neighborhood kids catching snakes with neighborhood kids. Chad, I love that. I want to hang out with you. They've talked about you being a pretty awesome guy, and now I see why for other reasons too. Sun, nice weather. Dave, do you mind jumping and reading some of these?
Yes. My baby niece, exploring nature, exercising. Yes, that's me. Walking and being with family, new puppies, and then training them to be certified therapy dogs. I love it.
Nice.
Love it.
Lauren, I'm going to go to you too. What are some things you're seeing here, Lauren?
Sure. I'm seeing, I think I see hearing my children laughing, which is beautiful. Last night we had a game night on Zoom. I absolutely love that. I love doing that with my friends. Living by a river, so beautiful. A lot of nature, a lot of activities, a lot of family. It's really, really wonderful to see all of these things.
I love it. Chloe, what's a few jumping out at you?
Collaging and cross-stitching, so we've got some creativity going on, working with our hands. Listing my home to sell, moving next to parents to care for them, so reconnecting with the people in our lives. Yep, I see all the puppies and the nature and my baby niece. Yes, the opportunity to strengthen the relationship with my children. So all sorts of wonderful things in all sorts of different spheres of our lives.
These are great. And thank you everyone for jumping right in. It's by design that we start with a focus on something that brings a positive experience. Even right here in this webinar, even in this Zoominar, whatever we're going to call this. It's really important that we start with something that's positive, something that brings us joy, and then we move on from there. So really intentionally modeling that. Hope is the thing with feathers that perches in the soul and sings the tune without words and never stops at all. We're honored to be able to explore hope, not just in terms of some of this type of a definition, the great poet Emily Dickinson, but also as an acronym, healthy outcomes from positive experiences. So how many of you have heard hope is not a strategy, right? It's often used in kind of a sarcastic, cynical way, right? Has anybody ever heard that? We're going to reverse that and say hope is the central strategy. Hope is the central strategy that we want to be talking about and working with. Something else that we're learning is, in spite of these very challenging times where we experience hurt, we experience frustrations, people are going through a range of emotions and uncertainties, some with grief and loss. It's important that we dare to allow our hopes to eclipse our concerns and our fears. It takes a courage for us to dare to allow our hope to eclipse our concerns and our fears. In our work with the science of the positive framework, which we're not going to unpack all of these layers, we do this in other publications and trainings, and much of what I did in yesterday's webinar. It's important, though, to acknowledge that we always start in the center here with a focus on the positive. And then there are these different steps and principles that we start to apply. But what's critical is we work from this place of this deepest belief, this core assumption, we call it a core assumption, that the positive exists, that it's real, and it's worth growing. It exists. It's something that we can actually experience, share, measure, cultivate conditions for. So we're always going to start from and touch this sense of hope, this experience of hope first, then we move on from there. So when we talk about hope, we think about hope being centered on this construct of the positive. It's real. Hope is anchored there as well. And the science of the positive framework is one of the foundational frameworks that supports the hope framework as well. We then move outward and we realize that the solutions already exist in our communities. I'm going to say it another way. Before we arrive, hope is there. Before we arrive, the positive is there. It doesn't mean it's not covered over with shame or historical trauma and a number of other things. But we can cultivate conditions to allow that to reemerge. We can cultivate conditions in individuals, in trusting relationships, in families, and we can do it across the social ecology, across the nesting of systems, so that we can allow hope to emerge, because the solutions, the positive, is already there. So how do we do that? One of the ways that we do it with our work is we move through this cycle of transformation. We go spirit, science, action, return. We're always moving in that same way. Spirit first, honoring the positive and the energy, having that kind of an experience like we're starting here today. Then we move into our thinking and our science. That's how we've designed this webinar as well. Then into action, change, integration, transformation. Here's where we utilize best practices, evidence-based approaches, data. Then we always come back to this return, a place of pausing, reflecting, evaluating, and the cycle continues. I like to oversimplify things. And if I had to oversimplify public health, talking red arrow, green arrow. We're going to be talking red arrow, green arrow stuff here today. And mostly we're going to be talking green arrow. In public health, we're all about reducing risk factors, right, for individuals and communities. And we're all about growing the protections, the support, the resilience. Many of us are mostly trained in the red arrow stuff. Some of my background came from that angle. So I'm over the past 20, 25 years have really moved more towards learning what this whole green arrow side looks like. And so the science of the positive is focused and recognizes both of these forces exist. We have concerns and risks, yet we also have hope and protections. And we can learn to integrate those. We're going to lead, though, by starting and focusing on the green arrow. So we're going to ask questions like this. What's in your green arrow? I'd like you to write that down off just to the side right now as you would. Not to answer right here, but I want you to keep this in mind. What's in your green arrow? What are the returns, the ROI, the positive things that you want to grow? What are the things that you want to see increase in the people that you serve? Here's another big aha. We need to focus on health if we want to grow health. We need to promote health if we want to see increases in health. It's not just enough for us to be the Don Quixotes out there going after the red arrow windmills and chomping away and smacking away at the things we don't want. We need to actually cultivate and grow health, because what we focus on is what expands. What we focus on starts to draw energy, and it becomes real in its consequences for what we start to measure, talk about, cultivate, and the narratives that we create. And so the rest of today, we're going to be unpacking some of these elements. And with that, I'd like to welcome my friend and colleague, Dina Burstein, Dr. Burstein, to jump in and bring us into the hope science.
Thanks, Jeff. That's a great introduction and a great segue into what I'm going to be talking about. But before I start, I just want to give a shout out to Dr. Bob Sege, who we've thrown out his name a couple of times, who typically would be participating in these workshops and webinars, but he's at his son's wedding. So we kind of thought that that was a reasonable excuse to miss out on the webinar, but
the nerve, right?
The nerve, I know, has his priorities all messed up. but that is why he's not here today. So here you see kind of a roadmap of what I'm going to be talking about over the next maybe half an hour. So I'm going to talk about the old science and how adverse experiences, how they affect the brain, and then go into the new science and then into action. How can we apply this new science to our professional lives and even our personal lives? So if we go to the next slide, I'm going to be doing a couple polls just to kind of feel out where people are in the audience. So if you could take a second to answer this. So how much do you know about adverse childhood experiences? And you can see the choices there. Nothing, a little, more than a little, well-versed, or you're an ACEs expert. I'll give everybody a minute to answer that.
Dave, have you go ahead and close it out when you think we've had enough folks come in here.
Thank you. So I'm saying that most of you at least know something about ACEs. No ACEs experts in the audience, or maybe you're all just modest. That's a possibility too. But there isn't anybody in the audience who's never heard of ACEs. So everybody has at least a little bit of familiarity with that. So given that, I'm not going to spend a ton of time on this, but so what are adverse childhood experiences? Well, when they were first studied, and now it's more than 20 years ago when that very important paper was published, these were the types of adverse childhood experiences that they were talking about and that they studied. So during childhood, did you personally experience some type of physical abuse, emotional abuse, or sexual abuse? Did you experience physical or emotional neglect, or was there household dysfunction? Somebody in the house with some type of mental illness, somebody in the house with substance abuse, witnessing interpersonal violence, like the mother being treated violently, your mother being treated violently, separation and divorce, and incarceration of a relative. So if we go to the next slide. So this is subsequent work that was done on ACEs, looking at the influence that ACEs have, so these adverse experiences during childhood, on adult health outcomes. And there's a lot of numbers on this slide, but if we focus on just the overall, the orange numbers on the right, we can see that's the fraction of people or percent of people who have these different diagnoses as adults that can be attributed to them experiencing ACEs, or adverse childhood experiences. And you see some pretty common things here. Coronary heart disease, so almost 13% is attributable to ACEs. Asthma, almost a quarter. Depression, we're getting up close to half. Heavy drinking, about a quarter. And even if you didn't complete high school, didn't get a high school diploma, almost 5%. So ACEs are very, very important and have a huge influence on health outcomes as adults. But when we think of ACEs, and when you look at what was asked in these original studies, you know, one thing that's missing is kind of the bigger picture. So it was very focused on the individual and individual adverse experiences. This shows the work of Wendy Ellis, who's pictured down in the corner of that slide, the slide. And what she described is that really you have to look bigger than that. So what are the roots of the ACEs tree? Well, they're community factors and societal factors. So things like poverty, discrimination, poor housing, violence in the community, all those things are really laying the foundation and the roots for ACEs. And if you're not asking about them and addressing them, then you're really missing an important part of the picture. So if we go to the next slide. So just to reiterate that, this initial kind of look at these adverse childhood experiences is missing something. So going forward, it's important to take into account these community and societal factors that also contribute to adverse experiences and ultimately to toxic stress. So poverty, racism. Okay, we're fine. We can go on. I guess, when you don't control your slides is anyway, no, that's fine. Go on to the next slide. One of the things that we're have a very close eye on and are very concerned with is developing a more equitable system. And HOPE begins to address this in several ways. So, and this will become clearer as we move on with this workshop. But in the more traditional provider-client relationship, it's always the provider that defines the problems and screens for the problems and maybe even labels people with certain problems. The hierarchy of power is clearly defined between the provider and the client. Families are often given labels, putting them in certain categories. And a big risk with this type of approach is individuals end up being blamed for things that are really the result of either current or historical systemic oppression. So if we go to the next slide, and again, this is going to become more clear as we work through this and do some different exercises, but what we're really trying to get across with the HOPE framework and the concept is that we're encouraging people to kind of change their approach. It's a paradigm shift or a mindset shift from screening for problems to an appreciation of strengths. Every family has strengths. Families are not broken. To change that power dynamic. So instead of it being, the physician or the provider here and the client here, that it's more of a partnership of joint decision making. And also recognizing that there are systemic causes to a lot of these problems and not all solutions are professional services. Thank you. So this is the diagram we have been working with. So we know that adverse childhood experiences can lead to toxic stress, and ultimately that can lead to poor health outcomes. But if we go to the next slide, so now we're learning that ACEs are really only part of the picture. And how do we know that? Well, first of all, many people who experience 4 or even more ACEs do okay. They grow up to be pretty successful, happy, functioning adults. So that starts you thinking, well, are there other experiences during childhood that are important and affect the brain? Do positive experiences affect outcomes too? And one thing I'd like you to do right now, and again, you can write this down if you want, or just keep it in your mind, is think of a person that you might know or that you do know that might have had a difficult childhood, maybe has an ACEs score of 4 or even more. But now they've turned out to be pretty healthy and successful adults. And if you look back, what you're familiar with their childhood, what might have been the key to letting them be successful as adults? What kind of experiences and supports during childhood? So if we go to the next slide. So that's it with the old science. Now we're going to move on to the new science and look what's being done with positive experiences. So we're going to do the same whole, but this time instead of ACEs, I'd like to know what you know about positive childhood experiences. And we'll give you, a half a minute or a minute to answer. All right, seems to be slowing down. So pretty different from the ACEs poll. It seems there's a group who's never heard of PCEs. Most of you have a little bit, you've heard the term before, but maybe you don't know a whole lot. No experts and only 2 people who feel well-versed. So that's great. Hopefully by the end of today, you will all feel well-versed in PCEs and their effects on health. So Dr. Sege, who's not here today, what he did, this was back in 2015, is he set out to study positive childhood experiences the same way that ACEs were studied back in that original 1998 study. So what they did in the Wisconsin Behavioral Risk Factor Surveillance System survey, they not only added a series of questions about ACEs, they also added a series of questions about positive childhood experiences. And then they looked for correlations between how people answered those questions and their reported mental health as adults. So if we go to the next slide. So these are the positive childhood questions that they added to that survey. So respondents were asked how often they felt able to talk to their family about feelings, how often they felt their family stood by them during difficult times, how often they enjoyed participating in community traditions, felt a sense of belonging in high school, felt supported by friends, had at least 2 non-parent adults who took a genuine interest in them, and felt safe and protected by an adult in their home. And you'll see when I get further in this talk how these start to form what we now refer to as the building blocks of hope, or the different categories of positive experiences that are so critical. So what did they find? Their findings were published in a paper this past fall. And if we go on to the next slide, over the next few slides, I will highlight some of the key findings. So one of the things they found, if they looked at people who reported having 6 to 7 positive childhood experiences, and they compared them with people who reported 0 to 2, and that positive childhood experiences, regardless of how many ACEs they reported. The people who reported 6 to 7 PCEs had a 72% lower odds of having depression or poor mental health as adults. And if you go to the next slide, you see the same comparison between the group, again, that reported 6 to 7 positive childhood experiences, now comparing them with the people who report 3 to 5. The people with 6 to 7 are still doing quite a bit better. They had a 50% lower odds of reporting depression or poor mental health as adults. And if we go to the next slide, so now what if we throw in ACEs in there too? How does that change the picture? So this is kind of a busy graph, so I will walk you through it. Basically, each of the different colored lines represents people reporting a certain number of ACEs. So the blue line at the bottom, those people reported having 0 ACEs. All the way up to the orangey yellow line on the top, those are people who had between 4 and 8 ACEs. On the y-axis, that's the percent that reported having depression or poor mental health as adults. And the 3 different points on the line represent within that group how many positive childhood experiences they reported. So if we just look at the orange line, and we look at, so those are all people who had between 4 and 8 ACEs. So the people who reported only having 0 to at most 2 positive childhood experiences had a 60% of them reported having depression or poor mental health, versus, again, talking about the same group, people reporting 4 to 8 ACEs, but now we look at the people who reported 6 to 7 PCEs, only just under 21% reported having depression or poor mental health as an adult. And you can see it holds true for not for the 0 ACEs, but for the others, for 1 ACE and 2 to 3 ACEs. So what they concluded from this is that positive childhood experiences can prevent and mitigate the effects of adverse experiences and toxic stress. And it seems to be somewhat of a dose-dependent phenomenon. So if we go to the next slide. So, how is this happening? It seems like, really, it was somewhat surprising. So now more and more research is showing that not only adverse experiences have a biologic effect on the brain, but positive experiences do as well. And I am not a neuroscientist, and I'm guessing probably most people in the room aren't either and don't want to hear a lot of details, so I'm not going to go into a lot of details. But there is a growing body of evidence that the brain is very malleable and the brain can heal, and positive experiences can actually help this healing process. So there have been a number of studies published on stroke recovery, where if you have a stroke, other regions of the brain can actually grow and increase their connections and make up some of the function that was lost from the stroke. There have been studies showing that positive experiences such as learning intensive meditation, learning to read, actually causes biologic and physiologic growth and changes in the brain. And actually, if we go on to the next slide, I'm going to talk a little bit about oligodendrocytes, because it's such a fun word to say. So what those are is they're like the superhighways in the brain. So if you just click the slide, Jeff, we'll show you what we mean by that. So there they are. So what oligodendrocytes do, those are neurons, and the long skinny tail is axons. They're axons. And neurons have to communicate with each other to send signals from your brain to other parts of your body. And they have to have a coating called myelin, which helps transmit that signal. So a nice healthy neuron is the one on the right with a nice coating of myelin on it. And so oligodendrocytes are the cells
I think Dina froze.
Oh, you guys all froze. Oh, I hate it when that happens. You can go to the next slide.
It was the dancing neurons that froze.
Must have been. They're too much for my computer. Sorry about that. So researchers have found that different types of positive experiences actually promote development of these oligodendrocytes. So things like exercise, having social interactions, environmental stimulation, and that negative experiences actually suppress their development. So things like a sedentary lifestyle or social isolation. And finally, if we go on to the next slide. So this is a study just done a few years ago, looking at the neurobiology of addiction and recovery. So they did a study with a group of people, and part of the people experienced binge drinking, and the others were controls. And if you looked at the people who had just experienced binge drinking, they had a significant increase in the size of the ventricles of their brain, which I'm not going to go into the details of what that means, but it was very different from the control group. And then if they stopped drinking and then they scanned them again, you can see from the pictures on the right and the graph that the brain recovered. The ventricular size went back to normal. So we know that being addicted to certain substances can cause physiologic and biologic changes in the brain, but the brain can recover as well. So we're going to launch another quick poll just to kind of see how everybody's feeling. I've given you a lot of information. So we want to just check and see how people are feeling about it.
Dave, go ahead and close this. Well, it looks like, yeah. So
yeah, it's good. Good. So people are good with it. Looking forward to finding out how it fits into their work, or beginning to see how it might fit in. So, and a couple people said all of the above. So that's great. So with that, we can keep moving. So now hopefully we're getting into the more fun part, the action part. So we gave you a little bit about the science of ACES. a little bit about the newer science of positive childhood experiences, the mechanism of how positive experiences might be affecting health outcomes, because they can actually influence the biology of the brain. Now, how do you put that into action? So that's what we're going to be talking about now. So the building blocks of hope. So these were put together by Dr. Sege, who we talked about before, and Charlene Harper-Brown. And what they did is, looking at the research, they grouped the types of positive childhood experiences critical to helping ensure, good health outcomes as adults into these 4 different categories. So relationships, environment, engagement, and opportunities for social and emotional development. And I'll go through them each in a little more detail. So what do we mean by these? So relationships. Relationships are critical from the time we're born, really all the way through life. So we're talking about that critical relationship between a newborn and a mother. As children grow, it's very, very important that they have nurturing, supportive relationships with other adults, and then eventually when they get older, with peers. And having these types of nurturing, supportive relationships are absolutely critical in childhood, but they're really critical throughout life, even young adults and adulthood. If we go to the next slide. So environment. So children need to have a safe, stable, and equitable environment in which to live, learn, and play. So it's really important that they have safe, stable housing, that they have adequate nutrition, adequate food, that they have access to a high quality education, and that they have access to safe places to play and interact with other children. If we go to building block number 3, so building block number 3 is engagement. And what we mean by engagement really is children and adults need to have a sense that they matter, that, you have a purpose, you matter, you're doing something important. Children need to feel as if they belong. So what could promote this type of experience for children could be, helping out the teacher in school with carrying out some sort of school project, or helping out in your community with, a food drive or a clothing drive. And now during COVID, I think we've seen ways that children and adults have stepped up to the plate and engaged with their community. For example, stories of teenagers who go shopping for elderly neighbors because it's not safe for them to go to the grocery store, or children putting their teddy bears in their windows as a sign of support for other children. And if we go on to the next slide. So building block number 4 is having opportunities for social and emotional development. So kids need to learn how to negotiate, how to work out disagreements in a constructive, nonviolent manner. So they need to have that opportunity to interact and play with their peers and collaborate and work out their differences in a productive manner. So we're going to do a little fun exercise here. So the first thing I want you to do is take a look at this cartoon, and you can use the chat box. I want you to just write in the chat box the different risk factors that you see in this cartoon. So if you click once, Jeff, that question will pop up. Here we go. So we'll give people a minute, and I don't know if Chloe, Lauren, or Jeff, if you want to start reading some of the risk factors that you see.
You bet. While y'all are flooding the box.
Yeah.
So holes in the wall, secondhand smoke, baby near the outlet. Lauren, what are some things you're seeing here?
We have insects, bugs, baby near the outlet, cigarette burning. We have kitchen cupboard open. There are chemicals out and accessible. There's a lot of clutter that could lead to accidents.
Yeah. Chloe, what's some more? Yeah.
I see some people mentioning the parent disengaged. There's no interaction from the adult in the room. Some unhealthy food potentially, referencing that pizza. The smoking, the exposed wiring. Those are some things that I see.
Yeah, clutter, baby, right next to the outlet, poisoning, unstable walls. Yeah. So Dina, back to you.
Yeah, so now what I want you to do is take a look at this picture again, and in the chat box, write the protective factors that you see in this picture. And maybe Jeff, again, you and Lauren and Chloe can take turns reading some of those off for everybody.
Yeah, so there's a spiritual presence, a picture of Jesus on the wall. There's an adult that's present in the room with these kiddos. There's animals, there's books, that the family is together. Again, Lauren, over to you.
Yeah, we're seeing here the baby is in a playpen. There are clearly toys present. The adult is reading. There's the presence of food, clearly enough for everyone. The siblings are together. Seeing pets again. All of the siblings are clothed.
Yeah.
Great.
Lauren.
Chloe.
Yeah, sorry. Chloe, what else are you seeing?
Sure. So people are mentioning there's electricity with the TV, access to technology, there's toys. Somebody's mentioning there's maybe another parental figure present looking at the coat and the boots on the chair. Again, that there's plenty of food.
Great.
There's, go ahead.
Back to you. Yeah, go ahead, Dina.
Thanks. So if we go to the next slide, I want to do another quick poll. So I want you to tell me which was easier. Was it easier to find the risk factors? Was it easier to find the protective factors? Or were they both about the same?
Got about half of you that have come in, more than half.
Yeah.
Look at
Give
you.
it another 5 seconds if anybody else who hasn't answered wants to answer.
Anybody else? And
okay.
yeah, Dave, go ahead and thank you.
Okay, so 71% finding the risk factors was easier. Nobody thought finding the protective factors was easier. And some people thought they were about the same. And that's very typical because that's how we're trained. We're trained to look for risk factors, to ask about risk factors, to ask about problems, and then refer people for help. And one of the big things that we want to do with HOPE and the HOPE framework is to get you to change your thinking, to change your approach so that, yes, it is important to ask about risk factors and to address those, but you are also looking for the positives and asking for the positives and the protective factors and celebrating those. So we want to change your professional norms from just being a screen and refer type model to an understand and support, somebody who actively seeks out these positives, these strengths, celebrates them, and helps to create more opportunities for them. So what we're going to do now is we're really going to try to show how that might look in practice. So we're going to show you a couple of videos. And this is Dr. Sege, and he's interviewing somebody who's a patient, not a real patient. And the first video will show you a more traditional interaction between a physician and a patient. So without a HOPE-informed approach.
Hi, my name is Dr. Segi. I'm here to do your checkup. I'm so sorry I'm late. I've been having a bad day. I'm really running out. I'm going to tell you all the ways in which I'm really in a rush. And I'm glad you're here. Your name is Lori, right?
Yes.
Okay, good. I'm going to ask you a few questions I ask all my patients. Please be honest. I'll keep your answers confidential. In the past 12 months, did you drink any alcohol more than a few sips?
Yes.
Did you smoke any marijuana or hashish?
Yes, I did.
Did you use anything else to get high?
No.
You know, it's very important to always tell me the truth. I'm going to ask you some more questions now. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs?
Yeah.
Did you ever use alcohol or drugs to relax, feel better about yourself, or fit in?
Yes.
Do you ever use alcohol or drugs while you were by yourself or alone?
No.
Do you ever forget things you did while using alcohol or drugs?
No.
Do your family or friends ever tell you that you should cut down on your drinking or drug use?
No.
Have you ever gotten into trouble while you were using alcohol or drugs?
No, not yet.
Okay. Okay. Just give me a second. Gotta go through these stupid forms and figure things out. Okay. Kelly, right? Kelly, it looks like you're at moderate risk, and I need to send you to the Department of Defective Teenagers. There's their card, and I'd like you to go down there and get yourself all straightened out. Now, before you have anything else to say, I got to run, but I'll be back to do your exam in a few minutes. Bye.
Okay.
Okay, I think Academy Awards are in order for both those performances. But so that may be a slightly exaggerated version of a typical screen and refer approach between a practitioner and a patient. Now let's look at what it looks like with a hope-informed approach.
Hi, Lori.
Hi.
My name is Dr. Segi, and we're doing your physical today. Thank you for coming in. I'm really glad that you're taking care of your own health. And I saw that you came in on your own, which is great. Before I get started, I want to ask you a couple of questions. You go to school, right?
Yeah, I go to Bozeman High School.
Mm-hmm. And how's school going for you?
It's been good. I get good grades. I'm a part of the choirs there. I'm active in music. I have a lot of friends.
Great. Sounds like you really belong. You feel like you belong at school.
Yeah.
Great. Do you think you might go to college afterwards or get a job or what?
Yeah, I'm planning on going to college afterwards, probably pursuing a degree in music.
Really? So you must really like the choir.
Yeah, I really love the choir. I sing around the city, and sometimes I'm featured as a soloist in songs.
Nice.
Yeah.
That's terrific because you're only 16. You're already a soloist. That's great.
Mm-hmm.
I'm going to move to the business part. So I'm going to ask you a few questions that I ask all my patients. Please be honest. I'll keep your answers confidential.
Okay.
Do you drink any alcohol? Excuse me. During the past 12 months, did you drink any alcohol more than a few sips?
Yes.
Did you smoke any marijuana?
Yes.
Did you use anything else to get high?
No.
Have you ever ridden in a car driven by someone, including yourself, who was high or had been drinking?
Yeah.
Do you ever use alcohol or drugs to relax or fit in?
Yes.
You ever use alcohol or drugs when you're by yourself or alone?
No.
Do you ever forget things you did while using alcohol or drugs?
No.
Do your family or friends ever tell you that you should cut down on your alcohol or drug use?
No.
Ever gotten into any trouble when you were using alcohol or drugs?
No, not yet.
Okay, I appreciate that, and I hope you don't. Thank you for answering your questions honestly. You're obviously a strong person. You're engaged. I know you told me last time that you watch your brothers after school. You're really part of everything. I'm a little concerned, though, and the thing I'm most concerned about is you've ridden in a car driven by someone who was under the influence.
Yeah. Because
that can be a real problem. And it sounds like maybe you drink in order to fit in because you have a lot of friends and stuff. Do you think you can do anything to prevent yourself from getting in a car with someone who's under the influence?
Yeah, I can plan out rides more efficiently next time if I'm in that situation.
Good. 'Cause I know you're strong. You're obviously doing well at school. You're pretty engaged. So you're able to do all of this. I just want to let you know that around the corner, there's Susie. She works in our office. She's a psychologist, and some of my patients find it helpful, particularly if they're struggling with something they feel like they ought to be able to get over, but habits die hard. So I'll give you her card, and if you think she might be helpful, please go see her. Okay.
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 Thank you.
Now I'm gonna let you be. I'll be back in a few minutes to do your physical.
Okay.
Okay, thank you. So if we can go back to the PowerPoint, but I think that I'm sure you kind of saw the difference between using the classic approach versus the hope-informed approach. And really he ended up getting the same information, but the dynamic was very different. The relationship that was set up from that was very different. So if we go to the next slide. So what we want to do now is, we're a little bit behind schedule, so we're going to start kind of moving a little quicker. But so we want you to think about what would it look like to do kind of a hope-informed assessment, something where you're in childhood experiences. So as opposed to just doing screening for risk factors and referring, we're doing an assessment that we're screening for positives. We're promoting these positive experiences, supporting relationships. So if we go to the next slide. So again, this really basically says the same thing. So we're looking for kind of a paradigm shift, a mind shift from just screening for problems and offering therapies or referring for treatments to identifying these strengths, these positive experiences, and creating opportunities for engagement and celebration. So we're going to go into a breakout group. We're going to make these pretty small, 3 or at most 4 people. Going to limit it to just 5 minutes because we need to be done with this webinar on time for everybody. So the key question that I want you to talk about in your group after you introduce yourselves to each other is, how can you envision incorporating a hope-informed approach to the work that you do? So we're going to break into groups and we'll reconvene in about maybe 7 minutes, so at 2:35. All right, welcome everybody who's coming back. I'm going to give everybody another half a minute or a minute or so to come back, and then we would like to hear what you talked about in your groups. So as you're coming back, I'm going to ask you to please share in the chat box some of the strategies and ideas you had of how you can use a hope-informed approach in your work. And then my colleagues can monitor that and we can share with everybody. Or if somebody's super brave and they want to come off mute and tell the group what they talked about, that would be fabulous as well. Okay, so Nicole said we spoke about prevention, spreading this to the entire community, using it to balance ACEs and risk factors. Did anybody talk about the videos and the difference that they saw in the videos, and maybe how that might help them in their interactions with clients? We would love to hear from you.
Dina, I like this comment, everyone, about looking at how in prevention, spreading this out to the entire community. Thanks, Alicia. Mm-hmm. But putting this out into the entire community, bringing this out systemically. So I love that. And Chad, in terms of engaging parents in an activity, exploring risk and protective factors to help them look at more at the positives. Absolutely. Absolutely. We need to have this become part of a skill set and a narrative and create some of those kinds of experiences. Lauren, what else are you seeing here?
Yeah, here I see Lindsay said something about prevention advocates focusing on targeted efforts and clinical training, linking prevention and treatment. Sounds quite amazing. It's one of those, that linking of relationships that is really important under our framework. Outreach to get information out during the pandemic, really important there as well. Bringing the science of hope to fortify what we do with educators now, super important coming up with the new school year and the new version of schooling. So really, really amazing answers in the chat box here.
Mm.
All right, well, these are great ideas. And, I think one of the things that that we realize is that hope isn't going to look the same to everybody. And every, different profession and, different types of practitioners can utilize it in a different way. And we're getting some of those ideas from some of the things that you're writing in the chat box. But in the interest of time, let's go on to the next slide. So just to sum it up, what we tried to get across to everybody today is that ACEs matter, but positive experiences matter too. And positive experiences have an effect on health outcomes as adults, both mental and physical health outcomes. And that traditional training trains us to always look for the negatives and to screen for problems and then refer for help. And we're not saying that that's not important and that you should stop doing it, but we want to change to a mindset where we're including positives and we're actively seeking out these positives and these strengths. And we change that dynamic between the practitioner and the client, or the physician and the patient. So I'm going to hand it over to Chloe now, because we have another activity that we're going to do before we close this out in the next 20 minutes.
Thank you, Dina. So in that spirit of changing mindsets, using more of a hope-informed approach, using a positive lens, let's turn that in on ourselves and think about, right now we're in the middle of a pandemic, and I'm sure that's on a lot of people's minds, but thinking of stories, either related to COVID or not related to COVID in your own life, or that you've heard, stories that inspire you, stories of hope. And you can just take a minute to think about that, and then share those stories with us in the chat box. Or if you would like to come off of mute and share that story in your own voice with the group. So feel free to just message me, or one of the other team members can point out if you want to come off mute and share a story of hope, a story of inspiration.
And actually, Chloe, if you want to go to the next slide. As you're thinking of your stories, and hopefully we'll have some brave people who will want to share their story verbally, maybe think of how they fit into the different building blocks of hope, what types of experiences you're describing, and does it just fit into one, or does it fit into multiple building blocks?
Here comes a story. Yeah, go ahead, Chloe.
Great. So we have a story from Wendy. Thank you, Wendy. A young teen in my church loves to bake. During lockdown, she started to issue challenges for others to also bake. They've been collecting some 8,000 cookies a month. Wow. And have been, they're being taken to homeless shelters and food banks.
Oh,
wow. Thank you, Wendy. And I'm just going to navigate to this poll. And let's think about, with this story of inspiration, which one of these building blocks you think is the best match, whether that's relationships, environment, emotional development, engagement, two or more, none of them. So just feel free to pop in the poll which one of those building blocks you feel this aligns with the most. All right, thank you all. Thank you for your votes. All right, so we see that a lot of people are saying that this covers 2 or more building blocks, and they can choose. And it's true, you can see, you can see sort of relationships, you can see engagement with the community. Jeff, do you want to pop in and add your comments to the story? Oh, Jeff, you're on mute.
Thanks, Chloe. I agree that I love how they blend across as well. And so many, I mean, you can see how it could touch on each of these. I love how it's creating these opportunities for social emotional development in terms of, going into the church and interacting with the different people, probably most likely different ages, engaging others, pulling people in to help organize, then going out into the community as well. And so just love this example. So thank you.
Yes, thanks, Jeff. And thank you, Wendy, for sharing that story. I see we have another from Alicia about talking with their son about too much video gaming, but he actually just sits on his headset and talks to friends because he misses them, using technology to stay connected, not playing games, just talking. Thank you for that story, Alicia. Just that creativity of using technology to stay connected. I'm sure we can all feel that at this time. And we have a story from Ben as well. Lauren, do you want to talk about this story?
Sure, I'll go ahead and look through it. It says here, Ben saying that he has a story he remembers. One of the teachers most recently was within a breakout room. She said that the track coach reached out to other kids who wouldn't normally go into track, but would get all kinds of kids. And there was one student who hadn't been very confident. And if it weren't for the head track coach getting him into track, who wouldn't have seen his confidence grow over that time. He saw his success carrying out in avenues like his friendships and his grades. And because of the track involvement, he was able to bolster his confidence to be involved in other activities as well, which is really amazing. And that definitely gets into our opportunities for social emotional development, our relationships, and engagement sectors, I would say.
Great, thank you, Lauren, and thank you, Ben, for sharing that story, and for whoever's story that was, for sharing that with Ben as well. And it says, Ben is not involved with track, FYI. Thank you for that addition.
Love that, yeah.
That clarification.
Right.
All right, are there any other stories anyone would like to share through the chat box, through coming off mute? We might have time for 1 or 2 more. All right, well, thank you all so much for sharing all of those stories, and we really appreciate you practicing shifting your mindset and also sharing your stories with us and with each other. I think we're seeing right now how that connection is really important at this time. So thank you again, and we hope you enjoyed sort of using that other way of thinking, that way of using hope.
Thanks, Chloe.
And apologies, I'm just going to skip through some example stories we had really quickly and pass it on to Dina.
Okay, so we're going to kind of wrap this up now. We just have a few minutes left. So, what now going forward? Well, really what we'd like to see is an integration of hope and the hope framework into trauma-informed care. Kind of awareness that childhood experiences, childhood memories, both positive and negative, are important, but also reassurance that history is not your destiny. And remember, I asked you, way back towards the beginning of this workshop, to keep in mind somebody that that maybe had a very difficult childhood, maybe has a high ACES score, but they really turned out pretty well. And now, given all the things we talked about PCEs and the building blocks, maybe you can start to identify, well, what were the experiences that person had, those positive experiences, those key relationships, key supportive relationships that allowed them to thrive despite experiencing ACEs. You can heal, presented briefly on some of the neuroscience, showing that your brain can heal and grow in response to positive experiences. There's no shame in getting help, and it works. And, I think we constantly have to be seeking out the positives, inventing better ways to live, looking for the positives in ourselves, in our own personal experiences, in our work, and in our communities. If we go to the next slide. So again, after today, we hope that you'll stay connected with us. Thank you, Dave, for putting our website URL in the chat box. Please visit our website. We are very actively updating it and changing it. And I'm going to talk about a specific page on our website in just 1 second. We do post a lot of blogs, a lot of COVID-related blogs from guest speakers. And we also have, if any of you are familiar with ACES Connection, we have a community on ACES Connection that's growing, which is great, and it's called Balancing ACES with Hope. So on the next slide, so this is our new page on our website, which was just launched this Monday, which we're very excited about. We want to hear both their professional and their personal stories of hope. And so we're encouraging people to click on that URL that Dave just put in the chat box and share your story. Maybe it's COVID related, maybe it's not, maybe it has to do with your work, maybe it has to do with your personal life. But I think by collecting these stories and sharing them with people really start to open their minds to all the positive things that are going on. So we encourage you to do that. And I think I'm going to turn it over to Jeff now to wrap things up.
Thanks, Dina, Chloe, Lauren, and all of you. What we'd like to do while we're kind of closing out here, 101 ways that you could incorporate hope into your work. And if each of you just shared one of those, with the 46 people that we still have involved, we could start to grow that. We want to share that out with people. So what comes to your mind about just some really small, practical ways that you could bring hope into your work? Your work as a preventionist, an educator, a clinician, policy development, whatever role that you might be in. What are some of the ways that you think you could bring hope into your work? Which means we're going to focus on the green arrow, starting to look at what it is we're trying to grow. Positive community norms. What are the norms of hope that we'd like to grow? As a clinician, we saw some examples of reframing the way we're going to do an intake and develop a different rapport relationship with a patient or client. So go ahead, if you don't mind, in the chat box once again. What are some ways? Language, I love that idea. Laura, yeah, so there's a whole shift in the public narrative that we can be looking at. And I think that we need to. It's very intentional. A hope-based approach has a different narrative. Life skills class, absolutely. That is absolutely a positive experience, and building on that. Thank you. Starting Zoom meetings intentionally with something positive. Laura, I love it. We always talk about spirit, science, action, returns. We're going to start spirit first, and starting with something positive is great. Building a faith-based prevention alliance, absolutely, connecting at our core level. Acknowledging someone's strengths that aren't acknowledged often. Oh my gosh, yeah. Ending Zoom meetings intentionally with something positive. There you go. So bookending it, we go spirit, science, action, return, and we're going to come back to that spirit, and we're going to bookend that once again. And so small, inexpensive reminders that we are valued. That, Wendy, that's cool that you're in that kind of an environment. Little examples. Like, I love this. A note saying you are a gem with a small gem-shaped candy. Love it. Practicing hope with coworkers starts to intentionally create a positive culture each day. This is so vital, and so vital now, I think, for all of us, in realizing the gift that we have of working in positive environments or positive cultures. And we need to tend to that ourselves first. Great, go ahead and keep flooding the chat box with this. And I'd like to just kind of bring us to a close and say, thank you for this incredible opportunity to engage with you and share with you. We hope this is a first and just a start of working with you and exploring this work together. And I want to turn it back over to you, Dave. So thanks.
All right, that was awesome. And if y'all can't tell, I like to bring the energy or bring the hope myself. That's my kind of style. It was a great time. Thank you all for taking time out of your busy days to go on this journey with us of bringing hope into our communities, and loving the engagement and those stories in the chat box. I hope the stories of hope form gets filled out now. There's a lot of good stories going on in there, so go to that link. We would also greatly appreciate your feedback on the post-event survey. We are funded by SAMHSA, and we are required to evaluate our services, but also we want to hear from you, because our role is to serve and support you. And big thanks to our dynamic presenters today. Thank you, Dina, Chloe, Jeff, and Lauren. It's been a pleasure, and we'll be in touch. Thank you all.
Thank you.